Welcome to the deep dive. Today, we're really tackling a core topic, immunizing drugs from Chapter 49, essential stuff for pharmacology and patient safety.
Absolutely. It's all about, how we help the body defend itself. Sometimes we train it, sometimes we give it a temporary boost.
And our goal today is pretty clear, right? We want to help you really get the difference between active and passive immunity.
Exactly. And cover the key drugs, how they work, the pitfalls, the contraindications, and what you, as a nurse, really need to focus on. Make it practical.
Okay, so before we dive into the how, let's nail down some basic terms. The vocabulary of immunity. First up, antigen.
Right. An antigen is basically any foreign substance, usually it's a protein, that triggers your immune system to react. Think of it as the intruder signal.
And the body's response to that signal, that's the antibody or immunoglobulin.
Yep, these are proteins made by your B cells, specifically designed to find and neutralize that specific antigen. Your body's custom-made defense.
So how do we know if this defense is, well, strong enough?
That's where the antibody titer comes in. It's a lab measurement. Tells you the concentration of those specific antibodies in the blood. It's how we check if an immunization actually worked, if you've got enough protection.
It's pretty amazing that the basic idea behind this isn't new. People noticed this pattern ages ago.
Oh, definitely, way back. Edward Jenner's the classic example, isn't he? Noticed milkmaids who got cowpox didn't get smallpox.
That link between a mild illness and immunity to a deadly one, that really kicked off the whole science.
It did. It led to the idea of deliberately triggering that immune tolerance, which is, modern vaccinology.
Which brings us to how the body naturally does this. The humoral immune response. B cells meeting an antigen.
Right. When that happens, B cells change. Some become plasma cells. These are the antibody factories, pumping out antibodies for the current fight.
And others become memory cells.
Exactly. Memory cells. They stick around long-term, remembering that specific antigen. So if it shows up again, the response is way faster and stronger. Cellular memory.
And it's that memory function that we're really trying to tap into with immunization, isn't it?
Precisely. Which leads us straight into the big difference. Active versus passive immunization. This is key.
Okay, let's break it down. Active immunization. What's the core principle?
With active, we give you something, a vaccine or a toxoid, that makes your immune system do the work. It stimulates your B cells, your memory cells, to produce antibodies.
So your body is actively building its own defense. Requires a working immune system naturally.
That's the catch, yes. But the payoff is huge. Long-lasting immunity. Often, it's permanent.
Okay, so that's active. What about passive immunization then?
Passive is different. We skip your immune system's production line altogether. We give you the antibodies directly preformed, usually as immunoglobulin or maybe an antitoxin.
Ah, so it's like getting a temporary shield instead of building your own fortress.
Good analogy, yeah. It's immediate protection, really useful if someone's immune system is weak or if the disease is super fast-acting, like rabies.
But there's a downside, right? You mentioned it's temporary.
Exactly. Because your body didn't make those antibodies. Your system, specifically the reticuloendothelial system, the cleanup crew in your spleen, liver, lymph nodes, recognizes them as foreign eventually and clears them out.
So quick protection, but it fades, doesn't last.
Right. Active is long-term building, passive is short-term borrowing.
And thinking bigger picture, public health-wise, the goal with active vaccination isn't just protecting one person.
No, definitely not. It's about herd immunity. If you get enough people immunized, usually the target is around 95% or more, the disease can't spread easily.
So it protects the whole community, even those who couldn't get the vaccine themselves. Maybe they're immunocompromised or too young.
Precisely. It creates a protective barrier for everyone.
Okay, let's zoom in on those active immunizing drugs now. The vaccines and toxoids, how do they actually work?
Well, they all work by introducing a form of the antigen to your body, but in a way that won't cause the actual disease. It might be a live virus that's been weakened, attenuated, we call it.
Or it could be a killed virus or a bacterium.
Yep. Or even just a part of it. Or a detoxified toxin that's a toxoid. Enough to trigger the immune response, but safely.
And you mentioned earlier that whether it's live or killed affects how long immunity lasts.
Huge difference. Live attenuated vaccines often mimic the natural infections so well, you get lifelong immunity from just one series. Think MMR.
Okay.
But killed or inactivated vaccines, they usually provide only partial immunity. Your body responds, but maybe not as robustly or for as long.
Which is why you need booster shots for things like tetanus.
Exactly. Those boosters are crucial to keep the antibody levels high enough for protection over time.
All right, let's talk specifics, some key vaccines. There's one pair that causes a lot of confusion and errors, DTaP and Tdap.
Oh yeah, this is a major safety point. The capitalization matters immensely.
Yeah.
DTaP, big D, big P, has a higher dose of the diphtheria and pertussis antigens.
And that's for?
That's the primary series for young children, from 6 weeks up to age 6. Gives them that strong initial protection.
Okay, DTaP for kids, then Tdap, little d, little p.
Tdap is the booster dose. Lower amounts of diphtheria and pertussis antigens. It's for adolescents and adults to maintain immunity.
And the risk is giving the wrong one.
Exactly. Giving Tdap to an infant by mistake means they don't get enough antigen load, they might not be fully protected. You have to check the formulation against the patient's age every single time.
Got it. Critical check. Okay, moving on. Hepatitis B vaccine, what's notable there?
The manufacturing is interesting. It's made using recombinant DNA technology. They actually use yeast cells to produce the viral antigen component.
Yeast cells. Okay, so that immediately flags a potential issue.
Right. If your patient has a known hypersensitivity to yeast, this vaccine is contraindicated. It's a crucial allergy check before administration. Standard for kids now, vital for healthcare workers too.
Makes sense. All right, let's talk about the one we all get, or should get, every year. The flu shot.
Influenza. Yeah, the challenge here is the virus keeps changing, shifting its antigens. That's why we need an updated vaccine annually.
And most are quadrivalent now, covering 4 strains.
Yeah, usually 2 A strains and 2 B strains predicted to be circulating. And you'll see different types. The standard is the IV inactivated influenza vaccine. That's the shot.
The intramuscular one.
Right. Then there's Flumist, which is a live attenuated vaccine given as a nasal spray. Different mechanism, different administration.
And what about older adults? I've heard about a high-dose version.
Yes, the high-dose Fluzone. It contains 4 times the amount of antigen as the standard shot. The idea is to give older immune systems, which might be a bit weaker, a stronger signal to produce antibodies, better protection for them.
Okay, now let's touch on some other live vaccines. MMR, measles, mumps, rubella, big contraindications here.
Because it's live, you have to be careful. Key contraindications include a history of anaphylaxis to egg ingestion, some residual egg protein can be in there, or to neomycin, an antibiotic used in production.
And the rubella part, that has pregnancy implications, right?
Absolutely critical point. Women should avoid pregnancy for at least, the recommendation is typically 3 months after receiving the MMR vaccine. There's a theoretical risk to the fetus from the live rubella component.
Huge counseling point. Okay. Shingles vaccine, there's been a big change here recently.
Yes, a really important update. We've largely moved away from the older live vaccine, Zostavax, to the newer recombinant vaccine, Shingrix.
And Shingrix is better.
Much more effective, yes. It's a 2-dose series, recommended for everyone 50 and older, and also for immunocompromised adults 18 and up.
Good to know. Anything patients should expect with Shingrix?
Well, it tends to cause more local reactions, soreness, redness at the injection site, and maybe some mild fatigue or muscle aches compared to the old one. Important to tell patients that's normal and expected. Shows the immune system is working.
Okay. One more active vaccine note, specifically a safety warning for varicella, the chickenpox vaccine.
Right. Varicella is also live attenuated. The really crucial warning here involves salicylates, like aspirin. Patients, especially children and adolescents, must avoid salicylates for 6 weeks after getting the varicella vaccine.
Why 6 weeks?
Because of the risk of Ray's syndrome. It's a rare but very serious condition affecting the brain and liver, and it's been linked to salicylate use during or after certain viral infections, including varicella. So, no aspirin for 6 weeks post-vaccine. Critical safety instruction.
Wow. Okay. Good to flag that one. All right, let's shift now to the other side. Passive immunizing drugs, the rapid response team.
Exactly. These are for when you need protection now or when the patient's own immune system just can't do the job. Maybe they're severely immunocompromised.
And you mentioned the main types before.
Yep. You've got antitoxins,
Right.
which target specific toxins.
Tetanus immunoglobulin is a common example. Then there are antivenins.
For snake bites, spider bites.
Right. They counteract the venom, minimize the poisoning, given immediately. And then the broader category is immunoglobulins, often called IVAG if given intravenously.
And these concentrated antibodies, usually IgG, pooled from thousands of human donors. They provide general antibody support.
You mentioned supply issues with these.
Yes, unfortunately there can be shortages. Because they come from human plasma donations, supply can fluctuate. This sometimes means their use gets restricted to only very specific FDA-approved conditions where they're absolutely necessary.
Makes sense. Is there a good example where both active and passive immunity are used together?
Rabies prophylaxis is the classic case study, Rabies is almost always fatal once symptoms start, so you can't wait for the body to build immunity after an exposure, like a bite from a potentially rabid animal.
So what's the protocol?
It's a double-barreled approach. Immediately, you give rabies immunoglobulin, that's the passive part, providing instant antibodies right around the wound site and systemically.
Okay, immediate shield.
Exactly. And at the same time, you start the rabies virus vaccine series. That's the active part. It's typically 5 injections over 28 days.
So you're providing cover while training the body for the long haul?
Precisely. The passive antibodies protect you, while the active vaccine stimulates your own immune system to create long-lasting protection. It's a perfect example of using both strategies.
Okay, this all leads us directly into the nursing process. This is where you, the listener, really come in. What are the absolute must-do assessments before giving any immunizing drug?
Top of the list, especially for active vaccines, is checking for immunosuppression. Is the patient taking corticosteroids, chemo, other immunosuppressants? Because these drugs can blunt the immune response. The vaccine might not they might not develop adequate protection even after getting the shot.
So efficacy is compromised. What else?
Allergies are huge. We mentioned yeast for Hep B, eggs, and neomycin for MMR. You get a thorough allergy history.
Right.
And always check pregnancy status. Many vaccines, especially live ones, are contraindicated or need careful consideration during pregnancy or lactation. Also, check for any current severe illness or high fever.
Okay, so if someone has a minor cold, can they get vaccinated?
Generally, yes. Minor illnesses without fever are usually not a reason to delay. But a significant febrile illness, that's usually a reason to postpone, especially for live vaccines. Consult guidelines and provider orders.
And just to reiterate the really critical contraindications.
Pregnancy for live vaccines. Severe immunocompromise, think AIDS. Active chemo also generally rules out live vaccines. You just can't risk giving a weakened but live pathogen to someone whose defenses are down.
Okay, now implementation. Getting the shot in the arm or leg. Any key points?
Follow the orders precisely for route and site. It's usually the vastus lateralis muscle, that mid-outer thigh for infants.
And for older kids and adults?
Deltoid muscle of the upper arm is standard. Technique matters for minimizing discomfort and ensuring proper absorption.
What about side effects? Patients need to know what to expect.
Absolutely. Minor reactions are common. Soreness, maybe redness or swelling at the site, possibly a low-grade fever, feeling a bit tired.
And how do you manage those?
Simple comfort measures usually work. Rest, maybe acetaminophen for fever or pain, not aspirin for kids after varicella, remember, and a warm compress on the site can help. Reassurance is key.
But we also need to be ready for the rare, severe reaction.
Always. Anaphylaxis is rare, but it's a potential emergency with any injection. That's why you must have epinephrine 1 milligram per ml concentration readily available whenever you administer vaccines. Know where it is, know the protocol.
Be prepared. And what should patients or parents be told to watch for after they leave?
Teach them the warning signs that need immediate medical attention. A fever over, say, 101 Fahrenheit or 38.3 Celsius. Any difficulty breathing or wheezing? Any unusual neurologic symptoms, drowsiness, seizures, or signs of shock or collapse? Report immediately.
And documentation is key, right?
Absolutely vital. Document the vaccine name, manufacturer, lot number, expiration date, the site and route of administration, and crucially, provide the patient or parent with a written record.
The immunization card.
Yes. And always instruct them to report any serious or unusual reactions. These should be reported to VA-ERIS, the Vaccine Adverse Event Reporting System. That's how we track potential safety issues nationally.
Okay, so let's try to wrap this up. Key takeaways from this deep dive.
I think the main thing is understanding that fundamental split. Active immunity. You train the body, it builds its own long-term defense using vaccines or toxoids.
Right. Building the fortress.
And passive immunity.
Yeah.
You borrow temporary defenses by getting preformed antibodies like immunoglobulins or antitoxins, the quick shield.
And the nurse's role is central. Assessing risks, checking contraindications, administering safely, educating the patient, being ready for emergencies.
Couldn't have said it better.
Yeah.
You are the linchpin for safety in immunization.
So, for a final thought to leave our listeners with, we've come a long way, haven't we? From Jenner and cowpox to recombinant DNA vaccines.
Incredible progress. We've eradicated smallpox, controlled so many deadly diseases, but there's still a challenge. Vaccine hesitancy. It's still a significant public health issue. And some of it, unfortunately, still traces back to that debunked fraudulent study from the early 2000s that incorrectly linked the MMR vaccine to autism.
Even though it's completely discredited.
Completely. Retracted, the author lost his medical license. but the damage was done, and the misinformation persists online. So the ongoing mission for us isn't just giving the shot, it's also about education, communication, and rebuilding trust in the science that saves lives.
A really critical point. It's not just about the pharmacology, it's about the person and the public trust.
Exactly.
Well, thank you for that deep dive. Really helpful breakdown.
My pleasure. Important topic.
And thank you, our listeners, for joining us. Until next time on The Deep Dive.